My name is Tammy Howe, and I will be discussing multiple sclerosis for CSD 588. I will begin by talking about the brain structures and their functions. First, we have the neuron, which receives, conducts, and transmits nerve impulses. Part of the neuron is the dendrite, which receives impulses from other cells. Each neuron also has an axon, which sends signals away from the cell body. And then there's myelin sheath, which is the fatty membrane that insulates the axon and speeds up the transmission of the signal or action potential along the axon. There are the nodes of Ranvier, which are interruptions in the myelin sheath where the axonal membrane is exposed to extracellular space. And the synapse, which is the junction where impulses pass between two neurons. In this image, you'll see that the dendrites are multiple, the dendrite bodies around the nucleus. There's the cell body. Then there's the axon, which threads through the myelin sheaths, which insulate each individual part of the axon. In between the myelin sheaths are the nodes of Ranvier. And finally, the chemical transmission continues through the axon terminal bundle. Multiple sclerosis is a neurological disorder affecting the central nervous system, and specifically it affects the myelin sheath of the axon. There's unknown etiology, but there are links to autoimmune disorders, viruses, genetic and environmental factors. There are between 250 and 400,000 people in the United States that have been diagnosed with multiple sclerosis. They're typically diagnosed between the ages of 20 and 50 years old. Women are twice as likely to be diagnosed as men. This may be due to the fact that women typically are diagnosed at a higher rate for other autoimmune disorders. In this picture, you will see how the damaged myelin appears compared to intact myelin. This demyelination of the sheath along the axon causes distorted messages to go through the central nervous system. There are 4 clinical forms of multiple sclerosis. They are in order of common occurrence: relapsing remitting multiple sclerosis, or RRMS. This is the most common type, and it accounts for approximately 85% of cases. It's characterized by discrete attacks that evolve over days to weeks, followed by some degree of recovery over weeks to months. In between attacks, the patient has no worsening neurological function, and in fact, some people may have regeneration of cells and amelioration of some of their symptoms. In primary progressive multiple sclerosis, or PPMS, it's characterized by a steady functional decline from the onset of the disease. There are no relapses for this form of multiple sclerosis, and it accounts for approximately 10% of cases. With secondary progressive multiple sclerosis, or SPMS, it's characterized by initial relapses followed by a gradual neurological deterioration that's not associated with acute attacks. And finally, in progressive relapsing multiple sclerosis, or PRMS, is characterized by a steady functional decline from the onset of the disease with later superimposed acute attacks. There's no real difference that can be distinguished between PRMS and PPMS until there's a relapse that occurs in progressive relapsing multiple sclerosis. How does MS affect brain functioning? Well, initially it starts with the demyelination that causes a disruption in the nerve impulse and blocks the signal. So as the nerve impulse is trying to come from the cell body down the axon, once it gets to an area where there is demyelinated sheath there, then that breaks down the signal and it blocks its ability to continue on. There's also an allowance of extracellular or transmission of extracellular bodies such as sodium or potassium to get into the axon where it's supposed to be covered by the myelin sheath. The axons may become damaged and produce irreversible neurological deficits. Due to these neurological changes, it can cause debilitating symptoms such as blurred or double vision, pain or numbness in the extremities, extreme fatigue, personality changes, and motor speech disorders such as dysarthria, which are commonly caused by muscle weakness, muscle spasms as well. Communication-related symptoms include dysarthria, most typically spastic ataxic or mixed spastic ataxic, dysphagia, which can be due to damage in the corticobulbar tract or lower brainstem, and that's more common in later stages, but it can occur at any point in the progression of the disease. There's cognitive impairment that may be affected or present, such as dementia, impaired sustained attention, information processing speed, conceptual reasoning, visuospatial perception, and working memory, as well as decreased word retrieval skills. And finally, one symptom that may affect communication and lead to social isolation is depression or unstable mood. And this approaches 50% or 3 times the prevalence in the general population. Additional symptoms of multiple sclerosis include symptoms of the central nervous system such as fatigue, cognitive impairment, depression and unstable mood, vision, nystagmus, optic neuritis, diplopia. Again, with the speech, symptoms would be dysarthria and dysphagia. Musculoskeletal symptoms such as muscle weakness, spasms, and ataxia. Sensory issues such as increased pain or hypoesthesia or paraesthesias. Gastrointestinal discomfort, incontinence, diarrhea, or constipation. And finally, urinary tract disturbances such as incontinence, frequency, or retention of urine. The role of the speech-language pathologist for someone who has multiple sclerosis is initially to evaluate for dysarthria. You can use assessments such as the French Dysarthria Assessment, 2nd edition, or the Assessment of Intelligibility of Dysarthric Speech. This would again be to determine if there is ataxic, spastic, or spastic ataxic mixed dysarthria that's present, and to what degree. You would also administer a test of cognitive functioning to see if there are any deficits in working memory, word retrieval, if there's any indication that there may be dementia that is developing at that time. One possible assessment could be the Cognitive Linguistic Quick Test or the CLICKIT. You would complete a comprehensive oral mechanism exam and swallow studies if needed. This is especially important when you are seeing patients or clients outside of the hospital or rehabilitation setting. It's especially important since they're not having round-the-clock care for their multiple sclerosis or for a crisis, and dysphagia can develop at any time if they're having a crisis. So it's important just to kind of stay on top of that and be aware of any changes in their ability to swallow. You would also assess the need for augmentative and alternative communication devices. This is especially useful for PPMS or PRMS, just because the progression of the disease may lead to the point where they need to have AAC devices to help with communication as the disease progresses. Most importantly, the SLP needs to provide individualized treatment with the goal of improving or maintaining communication skills for our clients. In conclusion, Multiple sclerosis is an immune-mediated neurological disease. It has an unknown etiology, although there are links to autoimmune disorder, genetic and environmental factors. It causes the demyelination of axons, leading to disrupted communication between cells. This can cause muscle weakness and spasms, blurred vision, cognitive changes, dysarthrias, dysphagia, gastrointestinal and urinary tract symptoms. There is currently no cure for multiple sclerosis. However, there are medications that may ameliorate symptoms such as inflammation and improve immune system functioning. Thank you for your time.